You're here today for the Psychological Factors in Pain webinar, and we're glad you're here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by CIRPD and Pain BC, and also in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I'll be moderating as well as handling the Q&A session today. And our presenter today is Ingrid Fedoroff. Ingrid is currently a clinical psychologist at the Complex Pain Center at St. Paul's Hospital. She also holds the position of clinical instructor in the Department of Psychiatry at the University of British Columbia. She obtained her PhD from the University of Toronto and completed a postdoctoral fellowship in the Department of Psychiatry at UBC. Her specialties include psychological aspects of chronic pain, post-traumatic stress disorder, mood and anxiety disorders, and she is actively involved in teaching and clinical supervision of psychology graduate students and psychiatry residents. Thank you very much for being here today, Ingrid, and I will hand it over to you.
Okay, thank you, Tanya, for that introduction, and thank you everybody who is out there virtually listening to this talk. And I understand that that there are people both who are pain professionals and people who do have pain and live with pain. And so I want to emphasize that my talk is directed at both, everyone, and hopefully you'll find some things that are relevant to who you are and what you do. So I am going to talk about the psychological factors in chronic pain, and my objectives today are to describe some of those psychological factors that I think are important and prevalent. Particularly the psychological aspects that they may have been created by a pain condition, but now operate somewhat independently in perpetuating chronic pain and contributing to that nasty cycle of pain and psychological distress. And then also, I want to talk about some actual strategies that that are useful for some of these issues. So that's the plan for today. So first of all, as much as our pain technology and interventions and so forth have very advanced, people still have pain, and what to do about it. Pain is a complex condition, as I'm sure many of you know. It comes attached to a variety of things. For example, medical uncertainty comes with pain. What is the diagnosis? What is the prognosis? Is there anything else wrong with me? And as you can appreciate, these are anxiety thoughts. Pain causes a lot of anxiety about what is going to happen with pain. It impacts on employment, whether one is able to work or how much pain disrupts or makes employment difficult. And that, of course, can lead to financial problems as well. Again, very stressful, causing anxiety. Depression is very prevalent in chronic pain, feeling helpless about the pain, feeling maybe hopeless about the future, and what your life is going to look like. Pain is a family issue as well. Pain affects everyone in the family. Often people feel guilty about not being the person they were, not being the partner they were, or being the parent that they were. So a lot of layers of guilt as well. Anger can also occur. Questions like, why me? Why did this have to happen to me? There could be anger towards the medical system if you feel you've not been listened to or treated appropriately. Many possibilities for anger. And in the psychology domain, some cognitive distortions. That is that often a thought may be based in reality, like I have terrible pain, but then the thinking around that can be amplified. My life is over, my life is ruined, which, as you can imagine, fuels depression and anxiety and despair. And finally, medication issues. When one is treated for pain conditions, often the medication comes with two edges there, and the side effects can be problematic: sleepiness, low sex drive, constipation, all sorts of things that again go into the mix and affect people psychologically as well. And I just want to highlight that there has been a fair amount of research done in the importance of psychological factors in medically indicated procedures. In other words, psychology is in many places. These studies here, Spengler, looked at patients undergoing an elective lumbar surgery. So medically indicated, no question about the diagnosis and so forth. And what they looked at was clinical outcomes: pain relief, improvement in function, decrease in narcotic use. And what they found was that people's recovery from the surgery was more strongly predicted by psychological factors rather than medical factors. Psychological factors being depression and anxiety. And most powerfully, the combination of medical and psychological factors predicted who was going to recover more optimally from the surgery. So there's a real strong role, and these studies are being published in surgery journals, so it is being appreciated by other healthcare professionals, the importance of psychological factors in standard medical procedures. So just keep that in mind. Now I want to go over a model that many of us work from, and it's called the fear and avoidance model. And the idea being that someone suffers an injury and goes on to have a prolonged pain experience. And as you can see on your screens, there's two arms, left and right. And on my right, as I'm facing the screen, we have people who don't catastrophize. And I'll talk a little more about what catastrophizing is, but it's low anxiety. So they're having a pain experience, but they're not particularly anxious about it. And these people go on to exposure, and what that means is that they resume their life roles fairly quickly after the injury. That is, they resume their family roles, perhaps their work roles, their social roles. They go on and get back into life fairly quickly, and they go on towards recovery. So this is the ideal pathway. However, it is not the pathway that we see at St. Paul's, because we see the more extreme, serious cases. So if you look on the left, we see people who do catastrophize. They worry immensely about what is going to become of them, what is happening in terms of the pain diagnosis, and maybe some other diagnoses going on as well. And catastrophizing is anxiety and feeling helpless, dwelling on the pain, and thinking of the worst possible outcome. And catastrophizing can lead to people avoiding. So they don't do activities. They avoid their friends. They avoid various life roles that they feel they can't manage anymore due to pain, due to their mood. They may become hypervigilant about their symptoms. That is, they notice when they have pain. They pay very careful attention to whether they feel more pain or they feel other symptoms. And they become afraid of moving because it might harm them, that is, make their condition worse. And when someone gets caught up in this, often depression sets in. They feel helpless and hopeless about their situation, and that goes on disability and makes for a very tough time to recover. So what we want to do is try and intervene on the left side to bring down anxiety, encourage more function, and treat depression. So that's what we're going to talk about. Key issues being how people interpret their symptoms. People get frightened. Maybe the symptoms are ambiguous, so they're not sure what something means. If they have back pain, does this mean they're going to be paralyzed? If you have a headache, does this mean I have a brain tumor? Has something been missed? People start worrying about what their symptoms mean. So some key points to identify is to look at mood and anxiety. And again, this can also be for the individual living with pain, is to say, hey, I know my mood can be affected by pain, and I can also get anxious by these various things that go along with pain. So being aware oneself that mood and anxiety can be affected, and of course for the healthcare professional to look at these issues. Function is important. What can you safely do? What is going to hurt but it's not going to cause you harm? How do you pace yourself so you challenge yourself but you don't overdo yourself and crash and burn? What is family and social support like? Do family and friends understand, or do they not get it? This can be very important. Also, perceptions of injustice, and I will talk more at length of this in a few minutes. One thing I look at is asking people what they do in a typical day. I think that tells us a lot about people's mood, and it also can help you check in with your mood as well. Or is the patient able to enjoy any kind of hobbies or recreation? That is, to feel pleasure, even if it's not the same activities as you once enjoyed, but are there things that you can enjoy? And that really speaks to a major piece of the depression, which is the inability to feel pleasure or happiness. Also speaks to concentration and motivation. Do you feel like doing these activities, even if you can do them? What's someone's exercise like? What is their sleep routine like? All these things are indicators of whether mood has been affected. A typical day also tells you a lot about function, which is also very important. What are you physically able to do within the house, your household tasks, your social family role, again, your hobbies? Are you afraid of re-injuring yourself? The whole idea of harm versus hurt. Am I just going to hurt, or am I harming myself and making my condition worse? Is a person an active or a passive coper? And actually, either end of the spectrum can be problematic. It's good to be active, but if one is overactive, as in crash and burn, that actually sets people back further. So it's finding some place in the middle, so you're not sitting on the couch 24/7, but you're not overdoing it either. So these things are important to evaluate in oneself or in one's patient. Again, what do family and friends say? We get messages from family and friends. People can hear things like, oh, it must be nice to have early retirement, or to live on compo, wage supplements, and this sort of message that you're taking advantage of the system. Or it can be too much support. So, oh, honey, just sit on the couch, I'll get your medication for you, or, oh, don't do anything, I'll do it for you. It's all well-intentioned, but it does stop the person from challenging themselves and trying to take as active a role as they can within the home. So what's happening in one's social milieu is very, very important, the messages you receive. Also, how is your job going? Even if someone is job attached, that is, they've got a job waiting for them to return to, research shows that if there is low job satisfaction, or there's high demands or high stress at the job, the person is less likely to return to that job. Even though there's a job waiting in the wings for them, it's much more complicated than that. And if the person doesn't like their job, there's a very good chance they won't go back. Here we've got two little mice running on wheels. Well, one's running, one isn't, and the little guy sitting down is saying, I've had an epiphany. That is, are they taking a break from work, or are they intending on going back? It's hard to know. But that could be a conflict for people. Do they try and keep at it, or do they take a break? Now, perceived injustice. This is this idea that people see their situation as being very severe, and the loss is not recoverable, and that there's lack of hope or for change or improvement. And one example is people being in a motor vehicle accident. So they may have been driving along, minding their own business, and they were in an accident, and now their life is forever changed. And not just in terms of pain and disability, but also being involved with an insurance company, which can be stressful. And also people may feel they don't have control over their life because now the insurance company is involved. I'm not saying this happens all the time, but it can. Or people feeling that they've got an injury or an illness that has caused some pain, and they wonder, why me? Why has this happened to me? And perhaps they feel the medical system has not treated them fairly or well, and people can feel that they have been mistreated, and they develop this sense of injustice or unfairness. Similarly, people having a work-related accident may feel that WorkSafe is not treating them fairly, or they're stressed out by dealing with the case manager. We see all of the above. And there has been some research out there, new as in 2012, looking at the relationship between pain severity and depression, because we know that depression often follows high pain. And these researchers, which is Dr. Sullivan, based at McGill University, they have found that perceived injustice, so feeling that you have not been treated fairly, is a moderator. And just very quickly, just to show you that this how this works, there's an interaction between pain severity and perceived injustice in predicting depression. So people who have low perceived injustice, so they feel life has treated them fairly, or the institutions they're involved with are treating them fairly, they are at less risk to become depressed, no matter how high their pain is. They can have low pain, they can have moderate pain, high pain. They're going to be less depressed if they feel they've been treated fairly. However, people who feel they have been not treated well or fairly, so they have high perceived injustice, are at greater risk to become depressed when their pain is high. So I think this is something that we all have to be aware of, is when people feel some institution or life in general has treated them unfairly, that they are at greater risk to being depressed if their pain is high. Another interesting aspect of pain is the influence of trauma. So physical trauma, like being in a motor vehicle accident. I'll just touch on this fairly briefly, but there's been studies that looked at people who were involved in car accidents compared to patients in a non-trauma induced pain. So these people were matched for the similarity of severity in the injury. Patients were matched on the medical exam, similar medical interventions, similar level of physical limitations. And what they found is that the patients who were motor vehicle accident victims had more limitations, more pain, less quality of life, and lower mood, even though physically they were matched in terms of injury severity and the medical interventions. So that tells us that trauma is something different. It is more than the physical injury to the person. And what's happening with trauma? One idea is that people's beliefs have been shaken. The world is no longer a safe place. We generally go along on the assumption that the world is generally safe, particularly living in Canada versus the Middle East, that we can go about our business and be safe. But if someone has had a traumatic event, like being in a car accident, the roads are no longer safe, and people are more likely to see the potential of accidents, close calls, and just see being on the roads as being much more dangerous than before their accident. Also, the world being a predictable place, if something unpredictable happens to you and it injures you, the world is now less predictable. And a just world, so again, if we expect society or ICBC or a family to take care of us, and somewhere along the line people fall short of that, people start believing the world is not as just or fair as they thought. So these beliefs, this change in beliefs, can then perpetuate the cycle of pain and, say, these post-traumatic symptoms. So that's giving an overview of some of the pain situations, some of the psychological aspects that are involved in it. And now the big question really is, well, now we know about what happens, what do we do about it? So I'm going to go over some interventions that are helpful. And where do you start? First of all, listen. And again, for pain professionals, you're going to be listening to your patients, but I also say patients or individuals who have pain to listen to themselves. What is going on with me? What am I afraid of? What am I worried about? What are my concerns? What is my body telling me? And then to say, what are we going to do? In the pain professional's office, it's this idea of collaboration, that the pain professional has certain skills that they can offer to a patient, but that the patient also has responsibility in terms of the self-management approach. What can the patient themselves do to help the situation? And that can be, and I'll go through a variety of possibilities as to what the patient can bring to the table. Again, for the person living with pain, their perspective, what are we going to do? It's a good attitude to go into your healthcare professional's office with that, appreciating that you want something and need something from this professional, and also what are you going to bring to the table as well in terms of managing your health and your pain condition. I like to start with the gate control theory. It's a very respected older theory that has been built on and revised on over the years, but it offers a great rationale for self-management. And that is, we talk about conditions that open the pain gate, that is, make the pain worse. And first of all, the physical element, that is the extent of the injury, and what is one's activity level. Too much, too little activity, that's aggravating the physical. It also takes into consideration the emotional state, so that we know that worry, tension, depression make pain worse. People feel more pain when they have anxiety and depression and stress. And the cognitive aspect, that is people focusing on the pain, being hypervigilant to pain symptoms and pain experiences, thus having less involvement in life activities because they're focused on themselves, and catastrophizing, thinking this is the worst thing that's happened to me in my life is over, so, extreme thoughts. And the gate control theory also offers conditions that can close the pain gate, that is, mitigate the pain. And again, in the physical realm, it's appropriate use of medication. It is counter-stimulation like TENS machine or massage or heat or cold. Appropriate activity pacing fits in here as well. It addresses the emotional, that is, trying to focus on positive emotions, getting enough relaxation, getting some rest. I know sleep is often a problem, but rest and relaxation can fill in some of the gaps when someone is not sleeping appropriately. And the cognitive realm, having practice concentrating on other things, activities, other people in your life, distracting yourself from the pain, and becoming more active or involved with your family, with friends, with community. Again, this is all based on what people can do, and we take that in small steps. So as I said before, the main issues are depression, anxiety, and perceived injustice. Depression, I think most people know what depression is. Feeling sad most of the day for at least 2 weeks, lack of pleasure, changes in energy and sleep and appetite and sex drive, lots of negative thoughts, lots of negative emotions. So some depression strategies. One is the cognitive activation. We know that depressed individuals are more likely to focus on negatives, But we ask people to think of some of the positives in one's life as well. Who's in your life? Do you have a pet? Do you have children? And what are the positives? And the bringing forward the positives does not negate the existence of the negatives. It's this appreciation that both can coexist. That yes, there have been some immense negatives from having pain and depression, and at the same time, the positives can live there as well. And to refocus your attention on the things that are going well. And to say it does not invalidate the negatives, but you want to fill out the picture to have a more full picture of life, of your life. And here we've got two fellows on an island. I'm just grateful we were able to turn our pants into shorts. There's all sorts of ways to try and rejig your current situation. So I encourage you to be creative. Physical activation is also really, really important. It's important for physical health and it's important for mental health. And there's been lots of research studies come out lately on the emotional positives of exercise. The key thing here is don't wait until you feel like it. You'll be waiting a long time and things will get worse before they get better. And this is about setting a regimen, some sort of routine that you can do regularly. But it can be small. The point is to have some type of structure and routine. And something you like. People say, oh, why don't you try swimming? Well, if you hate swimming, I don't recommend starting with swimming because you won't want to do it. Do something small and do something that you like. And here we go. We've got be honest. How much are you exercising? So, both for the health professional and for the patient is to take stock. What are you doing for a little bit of exercise? Function fits in with exercise, and that is choosing some functional goals, what you would like to do. And the key piece here is what you would like to do, not what you should do, but rather, because with pain and depression, often the fun stuff of life disappears because it's being replaced by some necessary things, and you've only got so much energy and ability. But this is about putting something back into your life that you like. If you like spending time with your dog, then you go for a little walk with your dog. If you like spending time with your kids, how could you do that? Or your grandkids. But something not based on an errand or something that you should do, but rather something that you would like to do. And set a hierarchy. In other words, start with easy. Easy is really good. So that could be a walk for 5 minutes. It could be sending an email to someone, just saying hi. It can be very minimal. But the key piece is do it regularly. Set yourself up to do something every day, something that you like. And it can be physical or it can be social. That is getting in touch with people you care about. Doesn't mean phoning WorkSafe. Means phoning friends. And again, you can do it as an experiment. Try an activity and see what happens. You may think, oh my gosh, I can't do that. That's going to hurt. It's going to exhaust me. I don't think I can commit to doing that. Well, that's fine. What you do is you set something small, and then you ask yourself after you've done it, was it as bad as you thought or were afraid of? Was it easier than you expected? And what happened with your pain? The pain before the activity, the pain after the activity, and maybe a few hours or the next day you might want to check in with your pain. But these experiments, you have to do a number of them sequentially. So a one-time off thing may not give you enough evidence as to whether that activity is right for you or not. You can always dial something back, but the key is to really set up a number of these behavioral experiments. Try going to the pool and just sitting in the hot tub. What was that like for you? Did you find that getting to the pool at that time of day was okay for you? Did sitting in the hot tub make you feel better? What did you feel like the next day? all sorts of variations of what you can do. Consistency and routine is really the key. Then we have anxiety. Here we have anxiety girl, but this applies to anxiety boys as well, able to jump to the worst conclusion in a single bound. And the anxiety is this excessive worry about events, which is difficult to control, and it interferes with quality of life and comes with a number of physiological symptoms, being agitated, muscle tension, increased heart rate, increased blood pressure. So worry is okay and normal. It's when it escalates into being difficult to control, impairs your quality of life, then we know we've got anxiety. One of my tips is give those worries airtime. That is, listen to them. Schedule time to think about worries, but not just before you go to bed. Do this during the day. And devote some time to really think about these worries. Write them down. Look at them in the clear day, so not nighttime rolling around in your head endlessly. But what are these worries? Write them down. There we go. Write them down. And then divide out the worries. What worries cannot be answered? For example, what will happen to me? Will this pain go on forever? These are considered to be unanswerable questions. You don't know the answer. Your doctor likely doesn't know the answer. So they're not worthwhile questions to focus on, because you can't do much about them. But what you can do is focus on the worries that could have some action. Is there something you're concerned about that really does need some action, and that you can do something about that? That requires maybe a phone call, or requires some type of intervention that you can take care of. Maybe not all in one day, but it can be divided out as to who you need to talk to, what you need to do in a hierarchy of steps. And that goes back to setting up a hierarchy of goals. And again, start with the easiest action first, so you get sort of a bit of practice. And then you can push it a little bit and say, of these actions, is there anything I could do today? Well, if it's not today, is there something that I can do tomorrow? So try and get yourself to actually act on something fairly quickly, and it will reduce your worries. And again, prioritize what you're going to worry about. Rather than every little thing, you've got 50 things to worry about, pick the top 3. Because otherwise you get overwhelmed with too many things on your list. That's just like with to-do lists. I never like more than 3 or 4 things on a to-do list. Otherwise it gets too overwhelming. And then the thing is, quit worrying. Your worry time is over. So this guy's sitting at home in his house coat. I thought I'd stay home today and accept the things I can't change. So the idea is containment. You're allowed to worry. You're allowed to think about these things and perhaps create an action plan, and then stop and turn your mind to other things in your life. And that's called containment. But do not worry. If you want to keep on worrying, you can worry tomorrow. Same time, same channel. So the idea is that you set yourself a routine for your worries, just like you do for exercise and setting yourself some goals. You can do the same with worry, but now it has a better chance of being contained, and you don't have them rolling around in your mind at night. Catastrophizing is when you worry about so many things, your mind doesn't stop, and the worries get even more amplified. And I'll just briefly go over what catastrophizing is. There's 3 sort of subscales to catastrophizing. Rumination, so dwelling on the pain. Magnification, being afraid the pain will become worse. And feeling helpless, that there's nothing you can do to manage your pain and it overwhelms you. People who tend to feel very helpless have poor outcomes in pain management. So that's an important place to target. And catastrophization can lead to, these were the things in the earlier model, fear of movement, hypervigilance, 4 symptoms, avoidance of work and social roles, mood disturbance. And the additional aspects of catastrophization, which I'm just going to go over briefly because I want to leave some time for questions. But one is this interpersonal aspect of catastrophizing. That is, how do you relate to the world and to others? So pulling other people into your distress, so that when someone asks, how are you? And someone might say, oh, I'm feeling terrible. My life has just gone upside down. I'm in a mess. I don't know what to do. It pulls in other people. People feel distressed themselves when they hear this, and they may not know quite what to do to comfort you. It's not to say that those feelings in a person aren't real, but it's also about a bit of containment, about how you want to communicate to other people, and how to get support and comfort from other people without overwhelming them. And people often talk about them being isolated or cut off from friends because people don't understand. And this might be part of the problem. Also, catastrophizing is a semi-logical leap to an illogical state. That is, that your original thought is based in reality. The pain will destroy me. I have bad pain. But it jumps to pain will destroy me, or my life is over. So you start with a realistic appraisal. I have bad pain, but it magnifies and it amplifies beyond what is rational. And the idea is to help people dial down from that. And catastrophizing, the state of anxiety, disrupts one's emotional state. It makes people more anxious about the future, more pessimistic about the future and themselves. So it goes in and prolongs the emotional distress and, of course, aggravates one's pain. And as I say, it causes a lot of physical stress, which interferes with sleep as well as emotional regulation. Catastrophizing, very briefly, predicts a number of things. If someone has a tendency to catastrophize, they are less likely to recover and resume life roles. They're less likely to return to work. The poor outcomes from a motor vehicle accident, and they will recover less well from medical interventions. So catastrophizing affects all realms of pain and medical conditions. If you're prone to catastrophizing, people do not do as well in recovery. So it's very important to identify this early, this tendency. What to do about catastrophizing? Again, the gate control theory is good for coping skills, learning some muscle relaxation. Breathing, I cannot emphasize how important breathing is to set a rhythm to your body, and also it calms the mind down as well. Cognitive restructuring, some of the things I've talked about, being aware of dysfunctional thoughts, which thoughts work for you, which ones are undermining you and making you feel worse. Having pleasant imagery, again, this idea of having positive thoughts in your world as well. And activity rest, so this whole idea of pacing, which is doing appropriate pacing, so being able to accomplish some things but not wrecking yourself in the process. Finding where that is. And all of these things are much easier said than done. When put into practice, they're tricky. They take a lot of perseverance. So, that was a lot of information. I appreciate that. So I'll try and summarize what we need to know here. One, psychological factors are powerful and need to be addressed directly. And collaboration is crucial. Collaborating with your healthcare professionals, collaborating with your family, collaborating with people in a support group if you've got access to that, because pain tends to be a very isolating and solitary experience. And the more that you can reach out and talk with people, either in a professional field or amongst your peers, amongst your family, very, very important. You don't have to do it all yourself. And I speak here to the healthcare professionals that this is a collaboration with your patient and other professionals involved in the patient's care. And again, for the individual living with pain as well, that to reach out, finding those supports in the professional world as well as your family and social world very, very important to reach out. Resources, looking for resources in the community, various books, audiovisual, online. There's lots of stuff out there. We ourselves like to suggest certain materials that we've vetted and know a bit about. But I find I lead a support group, and I know some of the members of my support group are out here, they're listening to me today, that we share a lot of resources. Other people who've lived with pain often have very good insights for coping. They have their own life experiences to speak to, which can encourage and inspire other people who are just starting this journey. So don't underestimate the resources that you as an individual have to contribute. And you can contribute those to your healthcare professional as well. Believe it or not, we don't know everything, and we learn a lot from our patients. So sharing really goes both ways. So, in conclusion, here we've got friendly cowboy here. No one is making you do anything you don't want. I'm just saying we're all headed for Dodge City, and we think you should come along. So let's all be on the same page and go the same direction. And that's it. Thank you.
All right. Thank you very much, Ingrid. We do have a couple of questions here online. So one of them was Brian, who I will guess is probably a health professional on some level, asking about the difference between early and late intervention for the psychological factors.
Early intervention is best, but as I say to my students and my patients, earlier is better than later, later is better than never. So I think for patients who are just starting this journey, to really check in with themselves and with the family doctor is a good place to start, saying, you know, I know that pain can cause depression and anxiety and messed up social situations, having fewer contacts with friends, that these are things you want to be aware of earlier rather than later. And as I say, it's always good to say start talking with your family doctor sort of the first sort of get-go for this, and then sort of monitor what's happening with one as we go along. So that's what I would say about early intervention. It's the ideal. We don't always catch everybody. But I think family doctors are becoming much more aware of the psychological aspects of pain and are able and willing to provide help right earlier on.
Very good. Also, we have another one who is a health professional asking, wondering what outcome measures you use for pain management and treatment.
I use a number of outcome measures. We use the pain catastrophizing scale, and that was developed by Dr. Michael Sullivan in McGill, and it specifically evaluates catastrophic thoughts towards pain. And I find something like that when I have the patient complete it is we go over it, and I may ask them, which one of these is most concerning for you? Which one really consumes you? And we can then help target something, because sometimes someone comes in and they're overwhelmed with their pain and they're overwhelmed with anxiety and so forth, and where do you start? And using one of these measures might help the patient to focus and contain a little bit more, and the two of you can work on a couple things that might help them manage their anxiety, for example. I use the Beck Depression Inventory as well. Now that test you have to pay for, but there's short versions of that are available to family doctors. I think there's a 7-item scale, and again it helps the patient sort of focus on what symptom is most problematic for them, or maybe the top 3 symptoms, and to try and target that for an intervention. So those would be the 2 main ones. I use a variety as well because I do conduct research as well. So the McGill Pain Inventory and so forth.
Very good. Let's see. We also have one Just one moment. I have another person who's a person with chronic pain who I've been chatting with a little bit online here, and she is saying that she co-facilitates one of the chronic disease self-management programs, but she also finds that she's obviously human and the techniques don't always work, and she still feels a fair amount of the isolation and issues around those, and just kind of wondering ways of maybe handling it in those moments where she's not feeling as strong or as capable, even though she does all these other activities that are helpful.
That's a very good point. We can't all be on, and we can't all be 100% all the time. And at first thought, I think I would ask this person to be a little more compassionate towards herself, that she is, doing a lot, but sometimes we all need breaks from being this great coper and this person who offers help to other people. It's maybe to take a moment to say, what do I need? I'm feeling burnt out. I'm feeling that I just can't have a lot more to give today. Then what do I need to refresh myself and look after myself? I think we all run the risk when we're trying to help people is that we want to do it so much that we can forget about ourselves in the mix. And if we don't have the energy and if we don't apply these principles to ourselves, that we're at great risk of burning out and feeling frustrated, or that we're not able to give as much as we would like. So checking in with oneself and being sure that you give yourself lots of self-care.
Very good. And then another comment from a patient with chronic pain, someone with chronic pain, saying they've dealt with chronic pain for 30 plus years and come to terms on a lot of aspects with their chronic pain, but also wondering, would you recommend seeing a psychologist on a regular basis for dealing with that side of the chronic pain issues?
I think it is a good idea. We don't have to all be, terribly depressed or terribly anxious to want the help of a psychologist or a counselor. And sometimes having a place to go and talk about stuff, dealing with pain and what your life is like, without burdening perhaps family or friends, that you can speak more freely. That can be a great outlet, just to sort of set your balance a bit and be heard and not worry about, say, upsetting or burdening other people. So it would ideally be great if someone, like the person who's asking the question, had a healthcare professional, psychologist, counselor, whatever, to check in with a few times a year, just to talk about the stuff that does come up. Just because you've dealt with it for 30 years doesn't mean that there's still things that are worthwhile talking about and sort of relieving yourself of that burden.
Very good. We also have a comment or a question from a health professional. It's a little bit of a two-part question. One is wondering, sorry, I just lost it there for a moment, what community support groups are available in the Vancouver area, but also wondering if you've had clients who have trauma as well, and whether EMDR, I'm not exactly sure what that is, or hypnosis have helped with trauma and pain?
Okay. First part, community support groups, I must say I don't know of any. I think the best place to find out maybe would be through the chronic pain self-management program, which is or administered through University of Victoria, because those are peer-led groups, and so there might be more information from that organization as to where people might be who would like to set up a support group. We have a support group at St. Paul's, but it is only accessible to patients of St. Paul's, unfortunately. But I don't know of any community support groups, I'm sorry to say. There may be some out in Sault Ste. Memorial Hospital because they've got a pain program out there now, but that's all I know. In terms of dealing with trauma and EMDR, eye movement desensitization, reprogramming, or processing. Yes, there is data out there showing that EMDR can be quite effective for trauma recovery. So I think it is a viable treatment. And hypnosis, hypnosis for trauma, I'm not really sure. Hypnosis for pain management, absolutely. There's a lot of research. It's really kind of old research, but it really does show the effectiveness of hypnosis for pain management. It's something that you have to get good training in and persist at it. And I would recommend hypnosis for pain management.
Very good. And just a few comments that both people have submitted, but also that I have, is that there are support groups being organized right now actually through the People in Pain Network. And
okay.
I can send out information on those. It's a new organization that just started up within the last year or so. And I know that there's a lot of work being done, and they should be going up in BC as well as Alberta within, I think, even this spring. So I can send out some information about that. Also, the Arthritis Society provides a lot of community support groups. While they focus a little bit more on arthritis, they do open them up to people with fibromyalgia as well as other forms of chronic pain. So it's worth checking out the Arthritis Society as well.
That's great. Thank you for that information.
Sure thing. And then let's see, what else do I have? There was one about noting the comment that you made about how people with pain are not always 100% all the time with their management and with being able to sustain that kind of attention it takes to being always coping, essentially, and wondering if you have any suggestions on how a pain patient can relay this message to their family and friends who don't always understand that aspect of it.
The aspect of not always being on 100%?
Right, and how they are coping and how they're doing well, but also they are not always able to be that on top of their game, so to speak.
Yeah, and this is something I point out to the folks I see who look like they're really good copers, and then people admire them for being good copers, and we all aspire to being good copers. And I think it's a very important message to the individual themselves and to the family and social network is that there's a downside of coping really well, is that people don't realize what a toll it takes and how hard it is to be such a good coper, and that there needs to be a time to take a break, to ask for help. But I think the coper themselves has to be able to be willing to ask for some help and say, this is not a good day, or this is a not so great week, and to be quite specific in what you want to ask from your family or your social support group. We all trick ourselves into thinking, I'm independent and I don't need to ask for help, but actually we do. So I think we have to be willing to describe what's going on, that we can't always cope at this 100% level, and what it is that you would like to ask from your support network.
Very good. That's great. So we're just about out of time. There were two more recommendations from someone who's participating for support groups and checking for online groups. You can check out at meetup.com. They often list groups of people who get together in person, but they organize it all online, and that there are often options for people with chronic pain on there, as well as looking at different Facebook pages and groups that might be either related to a specific disease that you have, or also for chronic pain as a disease in general, that those might be options to look at online.
That's great. I'm writing these down as you're listing them. So,
yeah, they're very good. Very good suggestions.
This to my, information that I pass on.
Wonderful. And then I will also write up a quick blog post with some of these resources as well to send out when I post the video online as well, so that people can have access to some of these. And then I think I'm going to go ahead and close down the webinar. Thank you everyone for joining. Thank you very much, Ingrid, for your presentation. I got a lot of good feedback, even just so far, on how this has been a really good presentation for people.
That's great. Well, thank you for inviting me, and it was a pleasure.
Wonderful.